So here we go, for arterial duplex imaging, take 2. I'm taking this stupid live camera off. You can deal with my frozen image. So we looked at the physiologic testing of the peripheral arterial. Now we're going to look at arterial duplex. Indications are really different. We always talk about the use of the physiologic as being much more beneficial in patients who are symptomatic and have previously not been diagnosed with any previous condition, because the duplex is actually better used in somebody who has had some sort of intervention. So anybody that's had bypass grafts, stents, angioplasty, or atherectomy, anybody that presents with a femoral bruit, and of course anything that represents acute arterial symptoms, which would be sudden. And we have to go with this acute as being they were fine and then all of a sudden these symptoms appeared. Rest pain, cold limb, and discolored limb. It's colored and usually bluish or maybe white. And of course anybody with suspected aneurysm or pseudoaneurysm. So when we do the duplex, we begin at the groin area, right at the area of the inguinal ligament. If you're just above the inguinal ligament, it's likely you're getting the external iliac. If you're at or just below, you're likely getting the common femoral. Common femoral is a very short segmented artery anyway. And then, of course, we image down to the bifurcation where we get superficial femoral and profundifemoris arteries. We really only need to demonstrate the proximal portion, but we do look at the entire portion of the superficial femoral artery as it becomes the popliteal artery, and then of course imaging further down into the tibio-peroneal trunk and both posterior and anterior tibial arteries. Unlike carotids, we don't really rely on the grayscale images as much, so this test is generally done looking at or following the vessels in color the whole way and just getting our spectral signals. If we do see plaque, we can turn the color off and do generalization, characterizations of the plaque. We'd use the same as we would with carotid. There's either hetero or homogeneous, smooth or irregular walls. The color is very useful for determining the vessel anatomy. It also lets us see collateral flow, locate any turbulence that may be associated with a bruit, and of course ultimately help us determine vessel patency. Our spectral signals are, again, analyzed much like they are in any other area. We look at them based on their phasicity, multiphasic versus monophasic, but we also quantitate the degree of stenosis from the duplex imaging as well. Obviously, much like carotid, we have velocity charts that'll demonstrate to us velocity changes that indicate hemodynamically significant stenosis. This is our current diagnostic criteria. It looks much like the carotid chart, except we're talking about limbs. And really, from the 0 to 16 to 49% category, it's very similar to. Presence of plaque is anywhere from none up to moderate. Color flow is always laminar because we don't consider it to be hemodynamically significant. And the waveforms are clearly going to be multiphasic up to that point. All velocities should be below 200 centimeters a second. What you will note is in peripheral arteries, we don't really think we're as good as zeroing in on high-grade stenosis. So we don't put them in categories of 50 to 79 or 80 to 99. We really just use a category called 50 to 99 or greater than 50% stenosis. Obviously, when you have that, you'll have moderate to diffuse plaque. You'll now see turbulence with the color. You'll develop the monophasic signal, and the velocities will be greater than 200 centimeters a second. Or if you use velocity ratios, which we'll see in a minute, at least the doubling of the velocity from the proximal segment. I don't think occluded needs much of a description. A lot of plaque, no signals. Bypass graphs are interesting in that they have a little bit different velocity criteria because the material that they use is not that of a native artery. So we can actually get a little bit better on degree of stenosis with these, oddly enough. But we have categories 0 to 19, 20 to 49, which you can see have relatively low velocities. And this is where we're actually comparing the velocity of the proximal portion versus the actual graft or stent itself. And this would be the percent change in velocity increase. Once again, once you get above 50%, you see significant change in velocity. So here we show it's clearly doubled. You'd see the turbulent flow. Greater than 75%, you'd have significant velocity increase, which would go with the doubling of the velocity ratio. And then occluded, once again, self-explanatory. And this is another way to look at these velocity ratios and determine a degree of stenosis. And this is simply by taking a segment just proximal to the stenosis or a stent and seeing how much the velocity doubles. So normal velocities may change anywhere from 1 to 1.5 times from segment to segment. But when they go anywhere above 1.5 times, then we're probably looking at significant disease. The 30 to 49% is a category that we can use that puts you in a velocity ratio of 1.5 to 2. 50 to 75%, you see significant velocity increases, and you see a velocity ratio that's anywhere between 2 to 4 times the proximal segment. And then anything greater than 75 is going to have a significant velocity increase with a ratio greater than 4 times the proximal segment. And then once again, occlusions really don't have any, they don't need any description. If it has no color fill, no signal, it's a pretty good guess it's occluded. So this is a demonstration of a normal common femoral artery with color flow. See, we've got our spectral signal placed nicely right in the dead center of the vessel, which is where it's supposed to be, with a nice Doppler correction, less than 60. And we see a good multi or bi to triphasic or multiphasic spectral signal from. This is at the area of the distal common femoral where it bifurcates into the profunda and the proximal superficial femoral artery. Very nice representation here of watching the vessel bifurcate. You can see the normal venous flow pattern that occurs between, as we will discuss later in venous, but you can hear it now. All deep veins and arteries travel together. So this is really going to be the femoral vein sitting next to the femoral artery at the proximal origin. You would see the same if we'd focus here, but this is primarily to demonstrate the bifurcation profunda femoris. Spectral signal from the profunda femoris. And now continuing on here, we can see the color signal from the proximal superficial femoral artery. In fact, you can still determine a little bit of the bifurcation here. Notice the color signal has no bleed over, so it's the color has been adjusted correctly at the proper scale. And of course, spectral signal demonstrates nice triphasic flow throughout. This is the distal superficial femoral artery. If you compare it to what you saw earlier, you'll notice that the arteries are now located a lot more deeper on the screen or in a more posterior aspect. This is one of the indications that you're reaching the distal superficial femoral artery or the area Hunter's Canal, because the arteries will begin to run deep from your scanning plane. You'll see when we switch to the back of the knee and look at the popliteal, they jump back up in the middle here again. But again, you see nice color fill. You see the vein demonstrated just below it. Color scale's too high to represent venous flow here, but it's a nice reference point. And of course, we have the right popliteal artery, which will not play for us. Isn't that nice? But hell, I've got half of them to play. I'm happy. So right popliteal with the takeoff of the anterior tibial. There we go. Popliteal artery. There's the takeoff of the anterior tibial artery coming off the popliteal, just at the area of the tibio-peroneal. This is the tibio-peroneal trunk, and there's another angle of watching the anterior tibial artery take off on its own. Of course, now we get down into the tibio-peroneal trunk. This is posterior tibial artery with a nice multiphasic signal. So this is looking at some abnormal cases. This is a demonstration of a high-grade stenosis in a stent. We can see the stent-like material here. In fact, if you examine this closely, this almost begins to look like it moves a little bit, which would be indicative of an acute occlusion. But this stent was placed in a common femoral artery. The outline of the vessel is pretty clear to see here, but you can see narrowing of the lumen with color turbulence. And of course, now you have a velocity well over 450 as we put the Doppler signal inside the luminal narrowing. So pretty indicative of high-grade stenosis in that area. Here we can see the profunda femoris artery. We can see a venous signal here, but you notice as we come into the proximal femoral artery, the flow just stops abruptly. If you look beyond there, you can see that the artery is filled with material. So this is classic of a totally occluded femoral artery. The other thing we'll take a peek at as well is with power Doppler and color angio comes into play. Remember, power angio really cannot determine direction of flow. It just determines flow, period. So this is the femoral vein, which we can nicely see flow in, but you can see here the outline of the femoral artery filled with material, and there is no detectable flow in there with the power Doppler or power angio. So therefore, that would be great determination that that vessel was totally occluded. This is what a normal stent should look like. You can actually see the origin of the stent here and the walls of the stent as it was deployed along the femoral artery. It has nice color fill, and after they're placed, they really ought to remain patent. This is interesting. That's probably a piece of the plaque that's behind the stent as they deployed it. So you can see where the original lumen of the vessel was. And then again, we're back to this re-stenosed stent. So you saw what they're supposed to look like. This is what they're not supposed to look like. Again, stent. This flow isn't even pulsatile anymore. It's primarily almost continuous going through this stenosed area. And then this, finally here are pseudoaneurysm. Pseudoaneurysms are generally related to trauma. If it's not trauma as in automobile accident, most of these are created surgically. Anytime we enter a vessel with a needle in order to perform any type of procedure, there's always the risk of developing. And ultimately what we've done here is we separated the media from the adventitia, creating a small little bulge that comes up through the artery. So here you can see this is the aneurysmal sac. This is the femoral artery, and this is what we call the neck. That's what's feeding into the pseudoaneurysm. These are interesting. They're not necessarily dangerous, but they're definitely painful. and have to be treated or the symptoms will not subside. So in doing that, what we realize is we have to determine the size of the neck to help determine the treatment. The three options are, if it's a really small neck and small pseudoaneurysm, sometimes it's possible to compress that area with an ultrasound transducer for 20 to 30 minutes and actually seal that vessel off. Other options, because that's got a low success rate, is injecting a material called thrombin. That's ultrasound guided, where you'll see the needle come into the pseudoaneurysm and a couple drops of thrombin in there will totally thrombose that whole pseudoaneurysm sac off. But it's the neck size that determines whether you can do that. If the neck's too large, it leaves the possibility of having a thrombin get into the artery itself, which would then thrombose the entire artery, which is not how you want to have your day go. In that condition, it would be require intracatheter thrombolytics for quite some time to undo your mess. And of course, if the neck is really large and they don't want to do the thrombin, they can just go in surgically and tie a little knot around there and just tie it off. So we see the artery, we see the aneurysm, we see the neck, and the final diagnostic criteria for that is to put a spectral signal in there, and you should see the back and forth or to and fro flow that we can see. It's classic in a pseudoaneurysm neck. So we call this bidirectional flow, and it's indicative of being in the neck of a pseudoaneurysm. Again, I apologize for whizzing through these, but unfortunately this is my second time through them, and you guys are on a tight schedule. And if you have any questions, you can always email me, and of course there's plenty of reference sources that I've supplied in here for you to see others.